this session is going to be focusing on opportunities to scale up TB preventative treatment and therapy. We have a great list of presenters, and it's my pleasure to introduce Andrea Howard. She's the director of the Clinical and Training Unit at ICAP at Columbia University, and she's also an associate professor of epidemiology at the Millman School of Public Health. She leads a team of professionals and oversees the design and implementation of ICAP's clinical, laboratory, and training programs for the prevention, care, and treatment of HIV and TB. Please help me in welcoming Andrea Howard.
Thank you and for that introduction, and thank you to the organizers for giving me this opportunity to present on TB prevention and HIV-associated TB. So in 2018, the WHO published recommendations that were updated and consolidated guidelines for programmatic management of latent tuberculosis infection. And these guidelines identified people living with HIV as a priority group in whom testing and treatment of latent TB infection was strongly recommended. Specifically, the guidelines included recommendations that adults and adolescents with unknown or positive tuberculin skin test and who are unlikely to have TB should receive TPT. And TPT should be given irrespective of immune status, and also to those on ART, those previously treated with tuberculosis, and pregnant women. In addition, infants living with HIV who are in contact with a TB case and are investigated for TB should receive TPT if there's no evidence of TB disease. And children with HIV in high TB prevalence settings who are unlikely to have TB after screening and have no contact with a TB case should be offered TPT. Now, this morning during the opening remarks, we heard that despite these strong recommendations, TPT coverage is inadequate. And I won't repeat all of the data that were presented already, but I just want to highlight once again that globally in 2017, among 59 countries with available data, TPT coverage amongst people living with HIV newly enrolled in care was only 36%. Now, ICAP at Columbia University supports TB-HIV integration at every level of the health system using 4 core approaches: technical assistance, implementation support, capacity building, and thought leadership. And I would like to do today is describe some select experiences ICAP has had in partnering with host governments to improve TPT coverage amongst people living with HIV, highlighting opportunities and challenges. And the examples I'll talk about today include implementation of a quality improvement collaborative in Sierra Leone, integration of TB-HIV services in reproductive, maternal, neonatal, and child health settings in Eswatini, and integration of TB-HIV services in opioid agonist therapy sites in Kazakhstan, Kyrgyzstan, and Tajikistan in Central Asia. So in 2017, ICAP partnered with the Ministry of Health and Sanitation in Sierra Leone to improve TPT coverage at 14 health facilities through establishment of a quality improvement collaborative, with the aim of increasing the proportion of people living with HIV who receive TPT from 3% to 70%. ICAP performed a baseline analysis to assess TPT coverage and identify barriers to implementation, and then developed indicators, data collection tools, and SOPs. Providers at the participating health facilities were trained in TPT, as well as in QI methodology. And through a series of learning sessions, QI teams from the health facilities came together to perform root cause analysis and then develop change ideas. And these change ideas were then tested using the Plan, Do, Study, Act cycle. Data were reviewed biweekly and plotted on run charts. And joint supportive supervision visits were conducted by ICAP, along with the Ministry of Health and Sanitation, to mentor facility staff on data collection as well as implementation of the change ideas. Now, during the project period, the 14 facilities conducted 78 Plan, Do, Study, Act cycles and tested 29 change ideas. And as you can see in the graph here on the right, during the first 6 months of implementation, shown in red on the right, IPT coverage increased from the baseline of 3% to a peak of 47%. Then there was a national stockout of isoniazid, and IPT coverage dropped precipitously. And over the project period, of the nearly 6,500 people initiated on TPT, 44% completed treatment, largely due to the INH stockouts, which were reported in 47% of facility months. 9 facilities did achieve their aim of 70% coverage when they had adequate stock of isoniazid. Now, despite the fact that there was a national stockout of isoniazid, there were several activities that were identified that really contributed to the successful scale-up of IPT in the early days of the project. And these included capacity building of the providers, both training providers on the importance of TPT, the national algorithm and QI tools and methodology, as well as a regular provision of feedback on progress towards the aim, as well as mentoring on implementation of the change ideas and the M&E system. Also important was revision of workflow processes, including optimization of patient flow and ensuring there was synchronization of refills for both ART and TPT. A lot of work was done to improve the commodity logistics system, including inter- and intra-facility commodity management and continuous stock monitoring, establishing a pull system. Critically important was patient engagement, both in terms of educating them about TPT and the benefits, and providing ongoing counseling and adherence support. And also obtaining detailed contact information so that patients could be traced very quickly if they did not present for refills. Another important lesson was that data quality and documentation were very important, and the team established automated data validation processes and dashboards in DHIS2 and had regular team meetings to review data quality as well as reports. In Eswatini, ICAP partnered with the Regional Health Management Team in Manzini to provide technical assistance to enhance integration of TB, HIV, and reproductive, maternal, neonatal, and child health services at 4 health facilities, including a hospital, a public health center, and 2 clinics. Again, healthcare workers were trained and mentored on intensified case finding and TB preventive treatment provision. In addition, lay workers, known as cough officers, were stationed in the waiting rooms to offer screening to all women and children presenting for services using a symptom questionnaire. And nurses at RMNCH provided TPT to eligible women rather than referring them elsewhere. A longitudinal register was introduced to capture information on the entire intensified case finding and TPT cascade. And here you can see the TPT cascade for people living with HIV. The totals are on the right, and then by point of service in the other bars. So in blue, you can see that a total of 1,958 women were screened for tuberculosis over the 9-month project implementation period, and nearly all of them had a negative TB symptom screen. And of the women with a negative symptom screen, 46%, shown in gray, initiated TPT. And TPT initiation was 35% amongst women accessing antenatal care, 22% amongst those in postnatal care, and 60% amongst those attending family planning visits. Now, among the 386 women who initiated TPT during the first 3 months of the project, 72% completed TPT. 69% completion was seen amongst ANC patients, 64% amongst PNC patients, and 73% amongst women in family planning. And data abstraction is almost complete for women in the remainder in the project period, so we'll have outcomes on the entire cohort. So through these results, we demonstrated that integration of TB/HIV services in RMNH settings is feasible and ensures high screening coverage amongst women of reproductive age. Overall, 74% of women attending ANC or PNC were screened for tuberculosis. Less than half of eligible women initiated TPT, although coverage was comparatively high amongst women receiving family planning services, and substantially higher than was seen amongst patients receiving HIV care and HIV treatment settings. However, further efforts to improve initiation and completion are needed. Once again, we saw that ensuring an adequate supply of isoniazid to meet the increased demand that was generated through provider training and patient education is really critical for success. At high-volume sites, providers found that task sharing with lay personnel was necessary to ensure proper implementation and continuity of interventions. But reducing the burden of extra documentation with the integration of key variables into existing registers rather than creating a new register will likely improve data quality and service integration. And currently, these integrated services are being rolled out at additional health facilities. Now, in Central Asia, ICAP has partnered with the Ministry of Health to integrate TB/HIV services in opioid agonist treatment therapy sites, 14 sites over the 3 countries. Historically, OAT, TB, and ART services are provided in 3 distinct service delivery sites at different facilities. But with ICAP support, there's been partial integration of these services under one roof, and the hope is that eventually there'll be full integration and co-location of services. So at these 14 OAT sites, there's regular HIV testing for patients and their sex partners, and patients are screened for TB symptoms every 3 months by the nurse who dispenses the OAT. Those that are HIV positive can enroll in HIV care on site and receive their ART, and there's ongoing adherence support and monitoring. Those with a negative TB screen who are HIV positive can receive TPT on site, and those with a positive screen are referred to TB services for further diagnostic evaluation and TB treatment, although they can return to OAT for the continuation phase of TB treatment through directly observed therapy when they receive their opiate agonist therapy. In this setting, the initial intensive phase of TB treatment is still provided in an inpatient setting. So since launch of the service integration in late 2014, 137 patients have received TPT as directly observed therapy at the 14 OAT sites in Kazakhstan, Kyrgyzstan, and Tajikistan. And amongst those people living with HIV enrolled on OAT in 2018, 31 initiated IPT and 84% completed the 6-month course by the end of June of this year. 21 of these 26 completed TPT while still on OAT. So really frequent follow-up of people living with HIV on OAT is an opportunity not only to provide regular TB screening, but also TPT via directly observed therapy. It's important to note, though, that some patients actually opt to receive HIV services elsewhere because they fear disclosure if they take their ART and their TPT in the presence of other patients when they get their OAT. And it's also important to note that access to OAT programs is limited in this region, particularly in Kazakhstan, limiting the number of people that can benefit from this integration. So in summary, provision of TB preventive treatment to people living with HIV in both high and low burden settings is strongly recommended by the WHO. But despite this strong recommendation, only 36% of people living with HIV newly enrolled in care received TPT in 2017. We've seen that quality improvement methodology can be used by health facility staff to analyze the root causes of poor TPT coverage and test change ideas, and that provider training, patient education, and streamlined M&E systems to monitor the TPT cascade are elements of a successful program. I cannot overemphasize that ensuring adequate drug supply to meet the increased demand is essential. An integration of TPT provision into other medical services, including RMNCH settings and OAT sites, improves coverage amongst key and priority populations, including women of childbearing age and people who are opioid dependent. I'd just like to acknowledge my ICAP colleagues, as well as colleagues in the ministries of health in the countries where we work, regional district and facility-based staff, and the recipients of care. And these projects were supported by PEPFAR through CDC. Thank you.